Good afternoon, everyone, and thank you for attending this web event for diabeteshealthequity.org. This project is made possible through a partnership with the National Center for Primary Care at Morehouse School of Medicine and the Bristol Myers Squibb Foundation Together on Diabetes initiative. My name is Richard Gooden, and I'm going to serve as your moderator today, and I'm expecting an engaging and eventful webinar, and I really encourage you to chime in with your questions, your comments, your concerns. Today's webinar is entitled Peer Support as a Strategy for Reducing Disparities, the Case of Diabetes. We're pleased to announce that it's been approved for AMA PRA Category 1 credits. So it's very important that if you are seeking continuing education credits for this event, you email Michelle Wimbush at mwimbush@msm.edu, or go to our website at www.diabeteshealthequity.org, and you'll see a link for completing the documentation necessary for these credits. Our distinguished presenter today is Dr. Ed Fisher. Dr. Ed Fisher is a PhD with the global and is the global director of the Peers for Progress program. It's a program of the American Academy of Family Physicians Foundation, and it's dedicated to promoting peer support in health, healthcare, and prevention around the world. Now, Dr. Fisher's been doing this for an extensive period of time, and I would probably cut into a lot of his time right now by going through his entire bio. But the highlights of it is that he's been published and he's reviewed chapters in publications on prevention, chronic disease management, and quality of life. In addition, he's also done publications and chapters for the U.S. Surgeon General's reports around weight management. His approach to these problems have included self-management, social support, and community-based health promotions, including studies of community-based programs for underserved minority groups. Dr. Fisher is also the past president of the Society of Behavioral Medicine and has served on numerous government advisory panels and the board of the International Society of Behavioral Medicine and the American Lung Association. Again, we're planning on having an engaging discussion with one of our leading authorities on peer support, and I encourage you to gather as much information as you can on this topic, and feel free to send any questions. I've already gotten the okay from Dr. Fisher to cut them off, and and ask any questions as they come in. So I encourage everyone to send your questions in. Again, I give you Dr. Fisher.
Thank you very much, Richard, and thank you, Morehouse, and thank you Together on Diabetes for hosting this and inviting us to make this presentation. I just want to emphasize what Richard just said. I think there's only one thing that's more boring than a 45-minute speech, and that's a 45-minute webinar. Please, Richard promises that he will not be bashful and will interrupt me as questions come in, and I'm happy if we don't get through all the slides. That's no great sacrifice. I really would invite your questions. So please, if you have questions, send them on in, and Richard, just repeat, please interrupt me as you like, as questions come up. So I'm delighted to present here on peer support as a strategy for reducing disparities. I think this is a really important dimension of peer support. We all know that much of the work on peer support, community health workers, promotores de salud, lay health advisors, is directed toward helping underserved communities, disadvantaged communities. But I think what's emerging in the literature, a little more specific than that general commitment to the underserved or the disadvantaged, is that peer support seems to be especially a strong strategy for reaching groups that we otherwise tend to often to see as hardly reached. I want to make two comments on terminology, both from that last sentence. I use peer support as a generic. By that we mean the individual, group, peer-to-peer process of helping people that is a major part of what community health workers do, what patient navigators do, what lay health advisors do, etc. So we use peer support as a generic, but we mean to include much of all of those groups in what we're talking about. The other thing I want to talk about is the hardly reached. We sometimes refer to people as hard to reach. That suggests that there's something about them that makes them hard to reach. I think increasingly we're recognizing that the problem is not with them, that they are hard to reach. The problem is with ourselves, that we have hardly reached them. So with that as a sort of academic preface, let's dig into some of this. I want to start, oh, this is my disclosure. I hadn't seen this, so I don't have any disclosures that would compromise this. And this is the announcement of credit that Richard mentioned. And here's the first substantive slide. I want to talk for a few minutes about this. And again, let me repeat. Throw in your questions to Richard if you have them. It's really important that we understand that peer support is based on something very fundamental about human beings. This picture is of a famous study that Harry Harlow showed back in the 1950s, that the monkey spent most of its time with the terry cloth, relatively comfort-providing surrogate mother. He only went and got on the other mother that had the milk provided when he was hungry. And what Harlow was trying to document or demonstrate with this study was that the need for what he called contact comfort was as fundamental as food. The little monkey preferred the warm terry cloth mother to the source of food except when it was hungry. And the point is perhaps a little bit too primitively made in this study and shown in the picture, but it's a really important point, and that is that human beings crave, need, cleave to other people. We like to have contact with others. We do better when we have contact with others. We feel more comfortable when we have contact with others. And this is reflected in a whole bunch of research as summarized in the text here, that all sorts of studies in psychology and human development, that human beings are more effective and happier when they have someone they can talk to, who cares about them, who can help them. And we just know, whether it's trying to help your adolescent child do well in high school, or whether it's taking care of aging parents, or whether it's trying to manage your own diabetes, we do better when we have somebody who cares about us, who we can talk to, who can help us with a favor. And this has been shown in a lot of epidemiological research, as summarized in the last bit of text on this slide, that the risk of death associated with social isolation, of not having other people, is greater than the risk associated with cigarette smoking. So what we're talking about when we're talking about peer support and social support is a really powerful fundamental characteristic of human beings. And it's important that we keep that in mind. Sometimes with these kinds of programs, there's a tendency to treat peer support as if it's sort of frivolous. Oh, it's nice for the candy stripers to do that on Saturday afternoons. Nobody gets hurt. But beyond that, as we're going to show in the presentation here, peer support can have really major benefits in health and healthcare. It needs to be taken seriously. It needs to be done well. needs to be implemented carefully, but when those things happen, the benefits can be real. So we're dealing here with an important, fundamental, strong, powerful characteristic of human behavior. Just to plug for our program, Peers for Progress, as Richard mentioned at the outset, is a program of the American Academy of Family Physicians Foundation, and we're dedicated to promoting peer support and health care, and prevention around the world. Here's our website, and I think you'll find a large number of resources, both for making the case for peer support as well as developing peer support programs on our website, peersforprogress.org. I want to just talk a few more minutes about some basic things, and then we'll get more directly into the topic for today. As you know, all sorts of people provide peer support. There are thousands of peer support programs around the world. As we took a look at all of this back in 2007 when Peers for Progress was getting started, we brought together with the WHO representatives from these countries listed here for a conference in Geneva, and we just spent days talking about how you would go about promoting peer support around the world. And one of the things we struggled with was the variety of peer support programs and how they're very much different in different countries. But what the people that came together in Geneva suggested to us was that the 2 points that are listed here. The key functions of peer support, the key characteristics are global. How they are addressed needs to be worked out within each setting. So we worked on that with Peers for Progress, and we've pursued these 4 key functions of peer support. They're very simple, but they turn out to be a pretty good template for thinking about peer support programs. Assistance and consultation in applying management plans in daily life. As one patient put it, the nurse and the doctor help me figure out what to do. The peer supporter helps me figure out how to do it. Social and emotional support to help me deal with the fact that in doing something like managing diabetes, sometimes my motivation gets a little bit thin, and I need somebody to help me keep my motivation up. Also, a lot of health problems that we deal with have a lot of stress associated with them, and it's often helpful to have somebody to talk about our feelings with. Linkage to clinical care, making sure people get the clinical care they need. Again, in the case of diabetes, the foot ulcer should be an outpatient visit rather than an amputation. And finally, ongoing support extended over time. We know that important but effortful behavior changes like healthy eating, keeping up physical activity, medication adherence, these things tend to decline over time if they're not continued, if they don't get continued encouragement and reinforcement, and peer support can be an important part of that. Now, all of these are also very pertinent to reaching underserved or hardly reached audiences, people who need, who have perhaps more challenges than others in finding a place to buy healthy food, or people who have a lot of stress in their lives and they need social and emotional support, people who may not have easy access to clinical care need a little bit of help in figuring out where and how they can get the care they need. And people who are having a lot of stress in their lives and need sort of somebody who's got their back and they know that they've got someone who they can talk to and who's going to be there for the long haul in helping them deal with their diabetes or their other problems, other health problems. So you can see how the 4 key functions of peer support are really pertinent in general, but they're also especially pertinent to the disadvantaged folks in our cultures, people with more problems in getting health care, those that are too often hardly reached.
Dr.
Yes?
Dr. Fisher, quick question I got from the audience. With your involvement with peer support in multiple countries, how do you address cultural competency?
That's a great question. Address cultural competency by really encouraging programs to be developed within their cultures. So we do not have a standard protocol. We don't have a standard curriculum program in the box. What we've been promoting around the world are these four functions, and actually it's a little bit what, as I think about it, what this slide is getting toward, that we have the four key functions, but then they are molded by local, regional, and cultural influences so that there is diverse implementation of the key functions according to local cultural perspectives. So peer support programs to us are almost always a marriage of the four key functions with local, regional, and cultural perspectives dictating how those functions get implemented.
I have another question from an Asaji, or Osaji. It's how do you determine the right level of training for your peers?
So that's a common question and a really important one. Increasingly, what we are learning from the program we've worked with is that what's really important, in addition to good training, is ongoing support and monitoring and assistance for the peers. The peers need to have somebody they can turn to when they run into a problem that they don't know how to handle. So the right level of training, in some respects, that's going to vary, but what's really important is that you have designed in your program support by professionals or program managers or perhaps very experienced peer supporters who can help the peer supporters deal with issues that come up. Another way of looking at Asaji's question is in terms of, what's the model for how much needs to know. And the way we've thought about it in a lot of the programs we've worked with is that the peer supporter needs to know as much about managing diabetes, say, as an experienced individual with diabetes, somebody who really knows their diabetes, has dealt with diabetes, understands what they have to do. They don't have to have the knowledge of a nurse or a doctor, but they have to have the knowledge of the practical characteristics of caring for diabetes that will allow them to troubleshoot and work with people and help them figure out how to apply their management plans to their daily lives.
One last question from M. Wimbush. Is there a certification program for peer supporters?
So there are a lot of programs emerging in the U.S. for certifying peer supporters. We think that in addition to that, it's important that we develop programs, or the states develop programs for certifying peer support programs, because a lot of times peer support programs want to be able to recruit a number of peer supporters and train them and get reimbursed for them, and we think that's an important model as well as certifying peer supporters. But a number of the states now are certifying peer supporters, and we're wanting to work with folks to develop ways of also developing guidelines for certifying peer support programs.
And do you have any evidence, Asaji, one other question, do you have any evidence-based curriculums for training peer supporters?
Yeah, several curricula for training people, as well as for other aspects of developing and managing peer support programs on our website. So if you poke around on our website, you'll find some good material there. And if people can't find it there, they can email me and I'll help them. So let me sort of just summarize what we've said. We've talked about the functions of peer support and how it needs to be implemented in different ways according to local, regional, and cultural influences in order to develop peer support programs that really do meet the need of individual communities and settings and cultures. I want to talk now a little bit more explicitly about the hardly reached, the disadvantaged, and this is just a summary of a lot of research looking at what are some of the barriers to that account for disparities in health in our country. The first is lack of network ties to sources of health information. People with college educations and white-collar jobs tend to know people who have information about where to get health care and who's a good doctor to go to and things of that nature. People who have less education, who are not in white-collar and professional jobs, tend to have fewer ties to sources of health information. So that's one thing that we need to think about when we're talking about disparities. As I suspect many people on the call are aware, distrust of mainstream sources, mainstream in quotes there, is still very much the case in the United States. Tuskegee is still very present in the thinking of lots of people, and people are reluctant to just take at face value advice about what they should do to take care of their health. Economic barriers to care and self-management are substantial. It costs money to take care of diabetes. It costs money to buy healthy food rather than less healthy food. So there are a lot of economic barriers to doing the things that we all would like to do to lead healthier lives. The disparities in neighborhood resources, availability of healthy foods in supermarkets and the like, or safe, attractive places for physical activity. We know that neighborhoods that have fewer supermarkets, less resources for physical activity, people in those neighborhoods have more problems with their health. They tend to weigh more. They have more problems with diseases like diabetes. So where you live really does make a difference in your health. And finally, as you know, there's continuing evidence that for discrimination among providers of health care, both conscious and unconscious. We know that people from ethnic minorities or low-income people are less likely to get some kinds of care than others, so we need to be attentive to all of those things. So that people have thought about how to address these kinds of causes of disparities, and four sort of guidelines that are pretty helpful are listed here: trust and respect, flexibility, partnerships working, and user involvement. And I want to just review each of these for a minute or two and talk about how peer support may be pertinent to them. First of all, trust and respect. An important part of peer support is that it comes from people like me. You know, the doctor may tell me that I really need to exercise 150 minutes a week, but that may tell me that it's important that I exercise for 150 minutes a week, but it doesn't tell me that that's really something realistic for somebody like me to do. My friend who lives in my neighborhood, who's similar to me, and tells me how they've been exercising and feel better, and it's really not that hard, they tend to be a lot more convincing than the doctor when it comes to the question of, can I really do this? So trust and respect from people like me is an important part of peer support. Peer supporters are usually drawn from the communities they're serving, and they have a likeness in their disease experience and their cultural experiences. Getting back to the earlier question about cultural competency, tripping over my language, peer supporters tend to bring with them a lot of cultural competence, as they are usually drawn from similar neighborhoods as those that we're trying to reach and engage, and people that we're trying to reach and engage. And then peer support, because it provides continued follow-up and support, really provides an opportunity for building trust. You know, a lot of folks who don't have much money in our country, they may rarely see the same doctor twice when they go for their health care. So the continuity of a peer supporter who remembers somebody, remembers their name, remembers their family member's name, remembers what part of town they live in, that continuity can go a long way to building trust and respect in a peer support relationship. Flexibility is a really important part of peer support, and we talked about how we've promoted, Peers for Progress has promoted the 4 key functions of peer support, but then encouraged their very flexible adaptation to different settings and healthcare systems and cultures. So as an example, a program in South Africa for women with diabetes found that frequently women attributed their disease to failings on their own part or even witchcraft, and they were quite religious in their orientation, and so their peer support sessions began and ended with song and prayer. That was just a usual part of their group peer support program. So that's just a simple example of how a peer support program in a particular setting will adopt and reflect elements of the culture in which it's being implemented. Another important part of peer support is that it's flexible to the individual. We try to encourage peer supporters to be able to be flexible and interacting with people in ways and through methods that are convenient for them. Sometimes they meet in local fast food restaurants. That tends to be a convenient meeting place in lots of neighborhoods. They may connect by telephone. There may be all sorts of ways that they connect, but flexibility in how peer supporters interact with people seems to be an important feature in reaching and engaging people. An important part of peer support is facilitating the partnerships of people with their communities, helping people get the clinical care and find the resources that they need. Peer supporters, especially if they have a functional relationship with clinical providers, if they're working out of a federally qualified health center or a community clinic, they can help people get the clinical care they need. And that seems to be a really important feature of peer support. Yes. Yeah, I think that's a really important point, and I'm glad Patrick brought that up. This is something we observe frequently in Peers for Progress, that where peer supporters are working with doctors and nurses, the doctors and nurses report that they get more insight into their patients by having the peer supporters helping them understand their patients. So in addition to whatever the peer supporters are doing, the doctors and nurses feel that they're doing better doctoring and better nursing because they have a better understanding of the people they're working with. So let me just finish this one point on partnership working. I talked earlier about how it's important that there be backup for peer supporters, that there's a nurse or somebody that they can talk to when they have questions that come up that they don't know the answers to. And another aspect of that is that when they have somebody that they're working with who needs some help in getting an appointment, the peer supporter should have contacts within the healthcare system that they can help the person get an appointment or figure out whom they need to see or how often they need to see someone or whether what they are dealing with really requires emergency care, that kind of thing. So that's another aspect of partnership working that's pretty important. Finally, a really important part of peer support, and this is pretty commonly understood, but we perhaps need to keep it in mind, and that is the user involvement in peer support. Peer supporters are almost always trained to engage in collaborative goal setting, to helping people figure out what they want, how they want to pursue things, what's important to them, so that the individual feels that they're really part of the team in interacting with the peer supporter rather than just being told what to do. And that, again, is a really important part of reaching out to hardly reached groups and reducing disparities. And so in Peers for Progress, we haven't advocated that peer supporters need to be volunteers or need to be paid or whatnot. We think that very much depends on the circumstances. I think where you're expecting peer supporters to really put in quite a number of hours a week and to be available for scheduled activities that they don't control. For instance, if you say, okay, you have to be here Friday mornings from 9 until noon, when there are those kinds of demands on the peer supporters, then it probably makes sense for them to be paid. In other settings, peer supporters are volunteers and may have a relatively light number of patients that they're working with, in which case it makes sense for them to be volunteers. In some settings, the peer supporters are technically volunteers, but they get a stipend of perhaps a few $100s every 3 or 6 months, something on that order, to help them defray the costs of transportation and just to sort of communicate honoring their time and their effort and their dedication. So I think that needs to be worked out within the individual setting. I will say that the Affordable Care Act has a number of provisions in it for reimbursing provider organizations for peer support services, and with that there should be growth in payment for peer supporters going forward. And Peers for Progress, along with our friends at the National Council of La Raza and some other groups organized through Together on Diabetes, are working on a policy brief and some materials to help people find ways of getting this kind of financial support for ongoing peer support programs. And I'll have a little bit more information on how to access some of that at the end of the talk. So I want to talk about just one program that we actually did in St. Louis, and this was an asthma coach, community health worker program for low-income single mothers of children who had been hospitalized for asthma and who were covered by Medicaid. So these were, the children had been hospitalized for asthma, but the program focused on their moms and helping their moms manage their kids' asthma. And the moms were all, as I say, low-income women with lots of stressors, lots of demands in their lives. The study design was fairly straightforward. It was a randomized controlled trial. The children were between 2 and 8. They'd been hospitalized for asthma, and we randomized 189 women and their children to either the asthma coach or the usual care. We took a standardized approach in terms of what the intervention focused on based on national standards for asthma management. We identified these 7 key asthma management behaviors, whether they had an asthma action plan, whether they were using prescribed controller medications, etc. And the peer coaches worked with the moms on each of those 7 key asthma management behaviors. And there was a defined schedule of planned contacts, but all of this was implemented in a very low-demand, persistent, non-directive, flexible approach. For instance, frequently when mothers were first contacted by the peer supporters after their child had come home from hospital, the mothers would say that the child was fine, that his asthma was better, and she didn't really think she needed much help. And what the peer supporters did in that case was just say, "That's great, I'm glad your child is doing well." The peer supporter described what they could do to help the mother, and then said, "I'm glad things are well, I'll check in with you next month." And the peer supporter would call back in a month to see whether there might be some ways in which she could be helpful to the mother. So if the mother originally declined to get directly involved with the peer supporter, that didn't disqualify her from any more contact, but rather it was just accepted as reasonable, and the peer supporters called back in a month. Another aspect of this that we ended up thinking was really important was that for many of the women that we were dealing with, if somebody calls them back, it usually is bad news. Somebody's calling them back to take something away or to question whether they qualify for something or something like that. And a number of the mothers really reported that they were really impressed that the peer supporter did call back in a month to check in with them, didn't have anything that they were demanding, but was just calling to keep in contact and to see whether at some point the women might have some way in which they wanted to get some help. There were some other ways in which we tailored this intervention to the mothers. We took a staged approach. Remember, we had the 7 key asthma management behaviors, and what we did was sort of identify which of those the mother was most interested in working on, and then we worked with the mother on that behavior. So the energy between the peer supporter and the mother was focused on things that the mother was interested in doing rather than trying to convince the mother to do something that perhaps she was reluctant to do. The peer supporters accepted the mother's feelings, reluctance to pursue some recommendations. They didn't badger the women. They sort of worked with them and worked with their perspectives. And very much flexible contact by phone, home visits, occasionally accompanying mothers to physician visits or meeting in neighborhood locations. So that was the low-demand, persistent, non-directive, flexible approach. And what we found was that this was really pretty effective in reaching these mothers. We were able to engage 35% of them within 7 days of being assigned to a coach, another 63%, or a total of 63% within 1 month, and 89% within 3 months. And the coaches were able to sustain that engagement over a 2-year period. So this approach, the low-demand, persistent, non-directive, flexible approach, really seemed to pay off in terms of engaging and encouraging the mothers to work with the coaches. And then the program was successful in reducing rehospitalizations over the 2-year period. Those who received the health coach had half the numbers of hospitalizations over the following 24 months as those who had usual care. So this program was seemed to be quite successful in reaching and engaging low-income, highly stressed, disadvantaged women with children with asthma, and really benefiting those children in terms of reducing their hospitalizations. I'm wondering if there are any questions on this particular study before I go on. I'm going to describe some others, but much more briefly. Yeah, this was sort of arranged as a research study, so we had a lot of research staff, and when we did this program, we weren't thinking as much as we should have about keeping track of what were the real costs, that, if you will, the generalizable costs of developing and implementing the program. But we reduced the number of hospitalizations avoided was substantial, and you of course know that hospitalizations are very expensive. So I think were we to redo this study today, we would show substantial cost savings through reducing the hospitalizations. Well, let me just talk about another one. This is a project we're doing with Alivio Medical Center in Chicago that's sponsored by Together on Diabetes. And Alivio is a federally qualified health center serving a large population of mostly Latino residents of Chicago. And in this program, we're trying to develop ways of a peer support program reaching the entire population of adults with diabetes, not just a few hundred who get recruited into a study, but really setting out to say, okay, how many people with diabetes is Alivio Medical Center serving, and can we reach and do something meaningful for all of them? And the way we've addressed that, or the way the people at Alivio have addressed that, is they've started out by estimating that they have about 3,800 people with diabetes that they serve, and they've divided that into the high priority and the normal priority folks. High priority, is detailed here, is defined by a hemoglobin A1C of over 8%, psychosocial distress, or physician's referral. The doctor just thinks, I think my patient would really benefit from this. And they identified 472 of the 3,800 as high priority, and those folks get individual contact bi-weekly, then monthly as they begin to make progress. And the focus of that contact is on encouraging their regular care, healthy diet, exercise, providing emotional support, etc. The normal priority folks, the balance of the 3,800, get education classes, support groups, activities, and importantly, they're contacted when they come through for routine clinic visits. So the peer supporters are linked with the clinical teams in the clinic, and they make themselves available during key clinic times so they can contact patients when they're coming in for their clinic visits. And we think this has been pretty successful to date. Well, this is a few months out of date. As of June of this year, we had contacted and engaged 89% of the 472 high priority cases and 78% of the normal priority. So I think this is just a very simple model, but it begins to take us in the direction of figuring out how do we tailor services to reach the different needs of different subgroups within an entire population of in this case, 3,800 people with diabetes. So in a sense, going back to the theme of this talk today, the high priority are the disadvantaged folks, the people who are suffering more with their diabetes, and we're seeing that the folks at Alivio, the program is able to reach about 89% of them. And what they're doing is really reminiscent of the asthma coach that I talked with you about a few minutes ago. They're taking a low demand approach. They initially call patients to describe their services, what they can offer them. But if the patient is initially hesitant to engage with the compañero, in this case, the compañero just says, fine, I'll call you back in 2 to 4 weeks and check in with you. And that's largely up to the discretion of the compañero to get a feel for about how frequently they should call people. They have pretty good instincts as to whether somebody really wants to be left alone for a few weeks, or whether somebody might be more ready to engage and might benefit from a call in just a couple of weeks. And as with the last bullet here, as with the asthma coach program, the compañeros are working with the patients on pretty specific diabetes self-management objectives, in this case based on the 7 key diabetes management behaviors of the American Association of Diabetes Educators. So that's the project at Alivio. I want to talk to you about a really exciting demonstration. This was a program that Peers for Progress supported out in San Francisco. And in this program, the peer supporters worked out of safety net clinics affiliated with University of California, San Francisco. The patients were Medicaid or Medi-Cal covered. Medi-Cal is a state program for indigent patients in California. And they were randomized to receive either peer support or usual care. And the outcomes listed here, you can see substantial improvements in hemoglobin A1C in the group that got the peer supporter versus the group that got usual care. What's in the graph there is even more exciting, and I hope I can explain this clearly. At the beginning of the study, the researchers in San Francisco gave everybody a measure of how much they were taking their diabetes medicine, so an adherence measure. And they divided people into those who were low, medium, and high on that measure of adherence. And then they looked to see how much the peer supporter helped each of those groups, those who were low, medium, and high on adherence at the start of the program. And what's circled there is really exciting, because the left-hand bar in the circle, the black bar that sort of goes up, is the increase in hemoglobin A1C among the people who were low adherers who did not get peer supporters. And the gray bar on the right in the circle that's going down is the reduction in hemoglobin A1C among the people who got the peer support intervention. So among the people who were low adherers at the beginning of the program, the peer supporter was especially effective. So this is really exciting. What it shows is that peer support may be especially effective at reaching the people who, in this case, were not adhering to their medicine at the beginning of the program. Let me show you a couple of other programs with similar results. This is a program that was implemented with Hispanic adults in 3 different inner-city health centers, FQHCs, community centers, and they were able to engage and improve diabetes management within this population of people with many disadvantages, again, people experiencing disparities in their care and their health, and too often hardly reached by our programs. In a program for Meals on Wheels among older adults, there was a heavy emphasis on health literacy, and this was also effective, and again showing peer support, in this case with older adults, as a way of reaching people who too often get left behind. Let me just summarize a few more. I've listed them here. The second bullet, in a program in Michigan, it was found that the peer support was more effective among those with low diabetes support or health literacy levels. So the peer support seemed to be especially effective in reaching those who indicated that they didn't have much support in their families and neighborhoods for managing their diabetes, or who were had high levels of or low levels of health literacy. Just skipping to the second from the bottom there, peer support was more cost effective among those with depressed mood or poorer baseline clinical status. Let me explain that a little bit. This was a cost effectiveness analysis of an entire program, peer support for low-income rural African Americans in Alabama. And what they found was that the peer support was most cost effective among the people who were depressed or had poorer baseline clinical status. So again, the peer support seems to be differentially effective in reaching and benefiting those who frequently we think we don't know how to reach and engage and help. I just want to put peer support in a little bit broader perspective here. I tend to think of peer support as under the umbrella of general community and social network approaches. And there are some interesting findings showing that these kinds of social and community approaches in general are effective in reaching the hardly reached. The COMMIT program was completed 20 years ago. It was a large community-based program for promoting non-smoking, and it was found to be especially effective among those without post-secondary education. So people without, who only had a high school degree or didn't have any education beyond high school, were especially benefited by the community-wide programs of COMMIT. In a program for Vermont women, the greatest reductions in smoking were among those with incomes less than $25,000. In a program we did in St. Louis called Neighbors for a Smoke-Free North Side, again a community-based program for smoking cessation, the greatest impacts were among those with incomes less than $20,000 a year. So there seems to be a theme across a lot of peer support programs and community approaches to health promotion that they tend to be especially effective in reaching and engaging people who have a lot of stress in their lives, who are low socioeconomic status, ethnic minorities, people who, as I say, too often our health care and prevention programs hardly reach. So I just want to close by mentioning that I talked about this a little bit earlier. With the support of Together on Diabetes and with our colleagues at the National Council on La Raza, we've developed the National Peer Support Collaborative Learning Network. The documents on the left there are available through our website, and in particular pertinent to the session today, we have advisory committees on all of the topics listed there: quality assurance, financial models, advocacy, etc. But one of our advisory committees is on special audiences and populations. And if people would be interested in getting involved in any of those advisory committees, they should contact the email listed there at the bottom. My colleague Sarah Barger, and her email is sbarger@live.unc.edu. That's an email address here at the University of North Carolina. So we would love to have people who are interested in these topics contact us and get involved. And we're really excited to have this opportunity to share these observations with you all today.